Thank you. My name is Dr. Richard Shaffer. I'm a clinical oncologist. I'm clinical lead for benign and skin radiotherapy for Genesis Care UK and medical director of Extral. I'm going to talk today about radiotherapy for heel pain. So in summary, I'm going to do an introduction to heel pain and its diagnosis, talk about general treatment options, talk about whether radiotherapy works at all, and if so, what dose, and then we'll talk about how to do it, and then a summary at the end. So plantar fasciitis is the most common cause of plantar heel pain, but there is a differential diagnosis. So for instance, there are local diagnoses such as heel pad atrophy, calcaneal stress fracture, and tibial nerve entrapment. There can also be referred pain with S1 radiculopathy or systemic diagnoses such as rheumatoid arthritis. And although most plantar fasciitis is at the insertion, it's not all there. So Young in 2012 did an ultrasound scan in patients who'd had plantar fasciitis for more than 6 months. He found that 66% of patients did have insertional disease, but 34% had distal fascial disease, and some actually had fibromas. So there are various words that are used in the literature. So Calcaneodynia, which really just means heel pain, and that really would be a clinical diagnosis. Heel spur syndrome, which would imply an X-ray diagnosis, and plantar fasciitis, which is either clinical or sometimes imaging, looking at the plantar fascia thickness with ultrasound or MRI. So these things have different implications, but often when we treat patients, sometimes there's no formal diagnosis, and there is the issue, does the specific diagnosis even matter? I mean, a lot of the time they're unified by inflammation, and really radiotherapy is used as an anti-inflammatory at low doses. So in this talk, because the literature varies a little, I'm going to use heel pain, calcaneodynia, and plantar fasciitis interchangeably. So just to talk a little bit more about plantar fasciitis. So it's a strain, tears, degeneration, and a lot of people use the word plantar fasciopathy instead of fasciitis. It occurs in around 10% of the population, and particularly in people between the ages of 40 to 60 years old. The cause is mechanical overload, so for instance, obesity, intense exercise, or poor footwear. 80% resolve by 12 months with conservative measures. And so really, when we're looking at considering other treatments, that's for resistant plantar fasciitis, where they've not resolved with conservative measures. So if we talk about the overall treatment options, so conservative measures include resting, weight loss, icing, stretching, changing the footwear, orthotics, and night splints. Once you've done that, talking about other treatments, so often people have steroid injections, but I have to say, we feel that they have short-term relief only, and there are, of course, risks involved. We'll talk about radiotherapy, of course, in some detail. PRP, or platelet-rich plasma, this certainly does have an effect, but it's quite slow-acting, and it is shown to be better than steroids. Extracorporeal shockwave treatment is widely available, but it can be effective in some patients, but there is quite inconsistent evidence. Surgery really should be considered as a last resort if non-surgical treatments fail. So let's talk about radiotherapy. Does it work at all? Well, OSS in 2013 looked at all the studies looking at over 13,000 patients and found a response rate overall of 85%. So that certainly implies that it works. And there have been 3 randomized trials of radiotherapy versus other treatments. So I'm going to talk about those in some detail. But just to list them, the Nevolt trial was radiotherapy with a standard dose of 6 Gray and 6 fractions versus 0.6 Gray and 6 fractions. Now, there are some that might consider that to be a control, although in the paper they say they do not consider it to be a control. Calcaneodynia in 2014 looked at radiotherapy versus a steroid injection. And again, perhaps one could consider that as a control. Calcaneodynia in 2016 looked at 3 Gray of radiotherapy in 6 fractions versus PRP. So let's talk about these in some detail. So the eligibility for the trials was plantar fasciitis for at least 6 months and failed conservative management. The workup and diagnostics differed a little. They all said they wanted to have an X-ray. Calcaneodynia and Nevolt wanted it as proof of a heel spur, and Calcaneodynia said that they wanted to rule out other causes. Neovolt wanted an orthopedic consult to rule out other causes, and Gonya also had an ultrasound scan to look at the plantar fascia thickness. And radiotherapy was given between 2 and 3 times a week. So Neovolt, it was a standard dose of radiotherapy, 6 gray and 6 fractions, versus a very low dose, 0.1 gray per fraction times 6. And the low dose treatment was assumed to be insufficient for pain relief, which is why I say perhaps one could see it as a control. The mean age was 56 years, all had to be over 40 years in terms of the eligibility for the trial. Mean duration of pain was 17 months, and more than 90% of patients found that sports and leisure was limited or impossible. And if there was a poor response at 12 weeks, then the patient was re-irradiated with a standard dose of treatment. Although if the patient had failed, then they remained in their dose group they started off as, with the results classified as unsatisfactory. On the interim analysis, there was a clear difference in response, so the trial was closed at that point to further recruitment. Now let's have a look at the results. So the VAS, the visual analog scale out of 100, so 0 being zero pain, no pain, 100 being the worst pain imaginable. And they started off, both of them, as 60 out of 100, roughly. At 3 months, you can see that the standard dose had gone down to 19, and the low dose, so 0.6 gray, had gone down to 41. So clearly there was much more change in the visual analog scale in the standard dose of radiotherapy. But interestingly, also, 64% of the low dose patients wanted re-irradiation, whereas only 17% of the patients who received standard dose of radiotherapy wanted re-irradiation. And also the effects were durable at 4 years. So the message of this trial is standard 6 gray radiotherapy is better than very low dose radiotherapy. So coming on to the next trial, Calcaneodynia, this was radiotherapy versus steroid injections. Radiotherapy was given as 6 gray and 6 fractions over 2 to 3 weeks. Very similar baseline characteristics to the Neovolt trial. And again, if there was poor response at 12 weeks, then they were offered further treatment of the patient's choice, so not necessarily radiotherapy. The visual analog scale was done out of 10, again, 0 being no pain, 10 being the worst pain. And the radiotherapy group was a little worse to start with. But you can see there was approximately double the reduction in pain with radiotherapy compared to the steroids. And also, if you add up the complete and the substantial response in the radiotherapy group, there was a 68% complete plus substantial response, whereas steroid only had a 28% response. So therefore, the conclusion of this one is that radiotherapy is better than steroid injection. Now, the Gonya trial was a little different. This was radiotherapy versus PRP. And the radiotherapy was given with 3 gray and 6 fractions, which we'll see later is a very reasonable dose. But in fact, they were very different patients. These were sports people. Their mean age was much less than the other trials. So remember, it was around 56 years old on average. These were 28 years old, and they also were just very fit. And if you look at their baseline characteristics, again, visual analog score out of 10 was 6.5, 6.6, similar in both groups. And they had a very similar change, actually. So really, on all the general measures, including plantar fascia thickness on the ultrasound, there was really no significant difference in response. So therefore, radiotherapy and PRP are equivalent, but I've also said in young athletes. So would that also apply to your normal patient? Maybe, but maybe not. So coming on to some of the details about radiotherapy, what fraction size and what total dose would you use? So there have been various trials looking at this. Sieg and Schmidt compared 5 gray and 10 fractions, which was better than 3 gray and 10 fractions, which was better than 2 times 6 gray and 6 fractions. So therefore 0.5 gray times 10 seemed to be the best regime that he used. Hayes looked at 3 gray and 6 fractions versus 6 gray and 6 fractions and found them to be equal. Ott also found the same, 3 gray and 6 fractions equivalent to 6 gray and 6 fractions, i.e. 0.5 gray per fraction is equivalent to 1 gray fraction. And Neovolt and Procane found also that if you try to give the same total dose, 6 gray, in 6 fractions or 12 fractions, really they're the same. So therefore, overall from those trials, we can see that the standard dose should be considered to be 3 gray and 6 fractions over 2 to 3 weeks, with each fraction being 0.5 gray. The next question is, should you give one phase of 3 gray and 6 fractions or 2 phases? Now, if you look at the response in the OTT trial from 2013-14, then you can see the baseline, they started at around 6.5, about 65 out of 100. After the first series, they went down slightly. 12 weeks later, they went down slightly more. If they gave a second series, then they did have an early response. The delayed response was 6 weeks later and they responded further. And then long term at 32 months, they responded further. So you can see that there was better pain relief after 2 phases than after 1 phase. However, it might be there would have been more pain relief if you would have just waited without giving the second series. And therefore, really, you shouldn't assess whether they need the second phase too early. So really, if you wait for about 3 or 4 months, see the patient, see if they've had either a complete or a really good partial response. If they've not had that, you could offer a second phase. But if they've had good pain response at that time, then they may well not need a second phase. You can save that radiotherapy dose. So how do we do it? Well, using a LINAC. On the left is one of my patients. You can see you include the whole calcaneus and the plantar fascia. It's fairly similar to what was treated on the trials. I use 6 MV opposed lateral fields, dose prescribed to the midpoint. If you're doing it with orthovoltage, 200 to 250 kV, it's a direct field, plantar direct field, generally around 6 to 8 centimeters, but that can be modified. And you put some bolus laterally and dorsally using what's called the Essen technique. And you calculate the dose to 5 millimeter depth. So in conclusion, radiotherapy is 85% effective in the treatment of heel pain. It should be considered if conservative treatments have failed for at least 3 to 6 months. The standard dose is 3 gray and 6 fractions over 2 to 3 weeks. And you can consider a second phase of radiotherapy if there's insufficient pain relief at 3 months. And it can be delivered either with a LINAC or orthovoltage techniques. Thank you.